evening, friends. Welcome to today's unique webinar on rational use of antibiotics in high-risk patient, and we are covering today diabetes and pregnancy. None other than Padmashree Professor Alaka Deshpande. Ma'am, please start.
Am I audible?
Yes, ma'am, you're audible.
Okay. Good evening, everybody. And today we are going to discuss rational use of antibiotics in risk patients. Dr. Asrani has already dealt with antibiotics with you. I'll just brush up the different classes of antibiotics that we commonly use. The first of all, penicillins. So penicillins, there are penicillins which were discovered, the penicillin by Alexander Fleming, and after that penicillin was inadvertently used, and therefore the penicillin resistance emerged immediately within few months to a year, and therefore there was a search for newer penicillin. These were semi-synthetic penicillin, synthetic penicillin, and they include amoxicillin, ampicillin, carbamazepine, penicillin G, piperacillin, all this you know. Now, all these penicillins have a beta-lactam ring. And there are organisms which produce beta-lactamase. And this beta-lactamase will deactivate this antibiotics. And therefore, we add clavulanate or sulbactam, tazobactam. So these act against this beta-lactamases, the enzyme which is produced by bacteria. That is how they enhance the antibiotic properties of these antibiotics. So you have amoxiclav, you have ampicillin, you have piperacillin, tazobactam, and then further higher antibiotics. So this is one group of penicillin. Then we have macrolides, and what I am giving you the classes of macrolides. These are, as you know, first is erythromycin. Now, because erythromycin was very commonly used for URTI and other minor infections, the development of resistance was also there, and then we found its hepatotoxicity. So we developed other macrolides, and they are azithromycin, clarithromycin, roxithromycin. Then we have fluoroquinolones. Now, fluoroquinolones, the first generation includes nalidixic acid. I don't know how many of you have really used nalidixic acid. Even I have not used. Of course, we have read it for urinary tract infection, but there was no occasion that we could use it. Then we have second generation fluoroquinolones, and that is norfloxacin, ciprofloxacin, and ofloxacin. Wonderful drugs for urinary tract infections. Wonderful drugs, they were also used for enteric fever. And today also we use it for many infections, which are gram-positive as well as gram-negative. But unfortunately, inadvertent use of norfloxacin and inadvertent use of ciprofloxacin, because the dosage was very, very convenient, there were no side effects. We are all scared to use ampi or anoxy because of diarrhea. So here with norfloxacin, ciprofloxacin, there was no diarrhea, and the dose was very convenient, twice a day, and therefore it was used like water for each and every infection, or even without infection. Therefore, very soon we developed resistance to ciprofloxacin. So even E. coli became resistant immediately, and then even enteric fever became resistant immediately. So please stop the inadvertent use of these antibiotics. But second generation ciprofloxacin, even today, in some cases, is very effective, and we are using it. So norfloxacin, ciprofloxacin, then came ofloxacin, once a day dose, and therefore it was antibiotic of choice of many people. The third generation was levofloxacin, sparfloxacin, and moxifloxacin. I remember when I was associate professor or something, sparfloxacin had come, but that caused very severe reactions, and therefore the sparfloxacin didn't become popular, at least in our country. Moxifloxacin, as we all know, that it is kept reserved for MDR TB, and therefore even Moxi and Levo in between had become very, very popular because once a day dose, and most of the medical practitioners for themselves used to use levofloxacin for any small infection, which even without antibiotic could have got cured. So again, for levofloxacin, there is a problem of resistance, but even then we keep this group for tuberculosis. And fourth generation, it has not yet come to India. Then we have cephalosporins, and we have first generation cephalosporin, that is cefadroxil, cephalosporin, and cefazolin. Second generation, cefaclor, cefuroxime, and cefprozil. Now these are very good. They have extended spectrum, gram positive, gram negative, wonderfully work on enteric fever also. But again, we have to use our caution to use them, because again, inadvertent use will cause resistance. Third generation is cefixime and cefotaxime. Then there are injectable cephalosporin. As you all know, cefotaxime, ceftriaxone, ceftazidime, cefoperazole. Now these are injectable, and the fourth generation is cefepime. Now this injectable cephalosporins and the fourth generation cephalosporin we usually use in the intensive care unit or for patients who are going into sepsis. And therefore, as far as possible, for simple infections, we can use penicillins, ampy, amoxi, or their combination. And we should reserve these for serious infections wherever the infections are serious and severe. In those cases, we can use these higher antibiotics like cephalosporin, injectable cephalosporin particularly. The second thing that we have to remember, that whatever antibiotic we are using, we have to use it in a proper dose and proper duration. Okay, we can't use it inadvertently. So the dose has to be proper, and therefore I would suggest you that get acquainted with one antibiotic thoroughly and use it. There is no harm if you use it frequently, because you are conversant with the antibiotic, its side effects, and its dosage. So these injectable, we keep them reserved for our ICU use and for the hospitalized patients. Then there are beta lactams. As I said, this is a ring. And there are lactamase. This is an enzyme produced by the bacteria which will deactivate these antibiotics. And therefore, now we have beta lactamase inhibitors. And these are carbapenems like imipenem, meropenem, doripenem, then cefoxitin, cefotetan, phosphomycin. All these, again, please remember that we keep them reserved for serious infection or sepsis. So they are used in the hospitalized patient, particularly patient facing a serious infection, admitted in ICU, and therefore we in our family practice don't use them. Nitrofurantoin is another antibiotic, antimicrobial, I would say. Beta lactamase inhibitors are clavulanic acid, tazobactam, and sulbactam, which I have already told you. Then there are certain non-beta lactamases and colistin. If all other medications have failed, then we have something left with us, and that is colistin. And then there is another group, that is aminoglycosides. These are gentamicin, amikacin, kanamycin. Wonderful drugs. They are very effective against E. coli, particularly Pseudomonas, gram-negative bacilli, and gram-negative sepsis. So we keep them again reserved. But their toxicity is ototoxicity and nephrotoxicity. So we have to be always aware about the urine output, the GFR, and the serum creatinine before we use it. And when we use it, we have to modify its dosage. Aminoglycosides are not at all advocated during pregnancy. So please remember that. But otherwise, they're very good for gram-negative infections, particularly Pseudomonas and E. coli. Now, today's topic Dr. Asrani has chosen is antibiotic use, rational antibiotic use in high-risk patients. And which are the high-risk patients that we are going to see in our practice? Commonly, chronic renal failure. Now, chronic renal failure, what are the common causes of chronic renal failure? Hypertension, which you must be seeing in your family practice. Diabetes, which are the two most common causes leading to renal failure. The third will be nephritis, chronic nephritis. Okay. And fourth is drugs induced. Now, when you see such a patient in hypertension and diabetes, when you are following up this patient, please do serum creatinine once a year. When the creatinine starts rising, make it twice a year. Now, don't measure only serum creatinine. You also measure eGFR. So you know what is the glomerular filtration rate, how it is reducing. It reduces as the age advances, but it also reduces with the severity of the disease and progression of the disease. Many laboratories only give you serum creatinine report. That is not correct. We also want to know the GFR. So please do that. So if the GFR is reducing and creatinine is rising, then please do not venture to use antibiotics in these patients. It is better to refer this patient to a nephrologist, get a guidance from him that which antibiotics will be safer to use in this patient. Because most of the antibiotics are metabolized and they are excreted in the urine. And therefore, when there is a kidney failure, we have to be very careful about the dose of these antibiotics. So when you have a patient who is going into a renal failure, please consult a nephrologist, take his opinion, and then you can use those antibiotics. Which is the another high risk patient? Malignancy. Now the incidence of malignancy is increasing, maybe because our diagnostic techniques have improved. People also have become very aware about it, and therefore we have malignancy. But usually all these malignancies are looked after by the oncologist. Now, once in a while, if this patient comes to you with infection, we can treat him like any other adult patient with infection, provided his kidney functions are normal. And most of these chemotherapeutic drugs, they don't have drug interaction with the antibiotics, so we can use it safely. But again, keep in mind about the serum creatinine. HIV/AIDS is another high-risk patient because this is immune deficient patient, but most of these patients suffer from opportunistic infection. But once in a while, of course, they will have pneumonia, which will be bacterial pneumonia, or they can have bacterial pneumonia, as they can have urinary infection, or they can have CNS infections like meningitis and all. So depending on that, most of the HIV/AIDS patients today they are receiving free antiretroviral therapy from the government program, and therefore government medical officers or the ART officers can look after them. But once in a while, if they come to you with an infection, you can treat them like any other non-HIV patient. Now, most common problem that we see in our family practice is diabetes. Diabetes is a lifelong disorder. We can keep the sugar under control, but the patient will come to us for years together, maybe 20, 25 years or even more than that. Same thing today with ART is happening with HIV/AIDS patient. The patient's longevity has increased and they are living for more than 25 to 30 years. So naturally, these people once in a while can come with infections, or the women can come with their infections, genital infection or skin infection, that they can be treated with our like non-HIV patient. So diabetes being a lifelong disorder, diabetes being complicated by many other factors, and therefore diabetes is prone to develop infections of various tissues off and on. And these are the people who will come in a family practice for our advice. So I'll be dealing with diabetes in little detail. And lastly, pregnancy. Pregnancy is not a high-risk patient. It is a physiological phenomenon. But in pregnancy, we are concerned with the mother, We are concerned with the fetus. We are also concerned with the obstetric outcome. And therefore, in pregnancy, we have to have guidelines to use antibiotics. Which antibiotics can be used, how often they can be used, how the patient should be managed. So today, although it is antibiotics in high risk patients, chronic renal failure, malignancies, I can talk about this, but that will be a separate class of 1 hour itself. And therefore, today I will be concentrating on diabetes and pregnant mothers, which you all people see in your family practice. Now, what happens to host defense in diabetes? Why diabetics are very prone to develop infections? Because diabetes has been defined as secondary immune deficiency disease. WHO defines it. Secondary immune deficiency disease. Some people call it as immune compromised disease. Okay. So there is an immune deficiency in these people. It's unlike HIV/AIDS, that is an immunodeficiency disease or a syndrome caused by a virus. Here, diabetes per se causes. This is called as a secondary immune deficiency or immune compromised patient. The polymorphonuclear cells, there is advanced glycation end products in the diabetes which alter the PMN function. There is a depressed chemotaxis. There is impaired phagocytosis. There is a decreased killing activity, and there is a decreased CD4 T response. Now, all this is immunology. I think Dr. Asrani is planning some classes on immunology. That time I'll be able to explain to you all this. But today you just remember that both the cellular and the humoral immunity is depressed in diabetes. And therefore it is called as secondary immune deficiency disease. In addition, the tissue susceptibility to infection increases in diabetes. In good old days, all the old people know that diabetic patient is prone to infection because there is a lot of sugar in his blood, and blood is everywhere in the body. In your skin, there is a blood, and therefore that blood on which the bacteria or microbes can thrive, and therefore diabetes is, prone to develop infection. Now we talk it more scientifically, why there is a tissue susceptibility to get infected. It is because of the immune compromise. There is an immune compromise that increases the susceptibility to infection and opportunistic infections. Vascular insufficiency. Diabetes causes microangiopathy and macroangiopathy. But the microangiopathy particularly is responsible for tissue hypoxia, and therefore because of the hypoxia there is a growth of anaerobes. Then neuropathy. It is a complication of diabetes, peripheral neuropathy. And because of neuropathy, there is an altered pressure distribution. And because there is altered pressure distribution, they develop certain pressure points, which always under the friction or even small injury will get an ulcer. And therefore, this ulceration will lead to infection of the feet. Unless it is controlled in time, otherwise it will take a very serious turn and maybe it will result into amputation. So immune compromise, vascular insufficiency, neuropathy. You all know we have taken a class on this, diabetic autonomic neuropathy. And one of the features of diabetic autonomic neuropathy is urine retention. Now, most of these people are elderly people. In the male patient, there is also a role played by benign enlargement of the prostate. But at the moment, keep it aside. Diabetic autonomic neuropathy is patient develops urine retention. And whenever there is any collection of fluid in the body, it attracts the bacteria. And therefore, these patients get bacteriuria or they get urinary infections. And hyperglycemia per se, as I told you, the sugar levels are high in the blood, which is circulating all over the body, and therefore this will help the growth of the infecting organisms, and hyperglycemia per se gives invitation to various infections. And this is the arthropathy in diabetes. And this is called as a rock bottom deformity or Charcot's foot. And you can see how the joints are deformed, and therefore it is causing the pressure points. These pressure points will easily get bruised, infected, ulcerated, and may lead or may result into a amputation. This is balanitis, which is again a common infection seen in diabetes. And these are boils. As you can see in this hand, there are boils. This is again very common. Now, what is essential is that you maintain personal hygiene, keep the skin dry. Okay. And then, because of the sugar, these infections are taking place. So, you have to highlight and impress upon the patient that it is very, very essential to control the blood sugar first. And then there is a paronychia. As you can see, there is an infection of the nail bed, that is paronychia. Sometimes it will develop into an abscess, and then it is really very difficult that you have to cut it open, cover it with antibiotics, keep on doing the dressing, and control the diabetes. The bottom line is control the hyperglycemia and then cover up these infections or treat these infections with antibiotics. And see the other picture which is showing you a swelling of the feet. Maybe it is going into a subcutaneous infection, cellulitis. And this is herpes zoster. As you can see, a pura dermatome is having the vesicle. So this is herpes zoster, which is again very common in diabetic patient. It is treated with tablet acyclovir, 800 milligrams tablet. Remember the dose, don't use a chicken dose of 200 milligrams. It is 800 milligrams 5 times a day for 5 days. At the same time, the patient should also be advised topical acyclovir ointment, because these vesicles, or because they are occurring along with the nerve, that these vesicles are very irritating, burning, and they cause a severe pain. So topical acyclovir ointment and oral tablet acyclovir for herpes zoster. And this is carbuncle. You can see the carbuncle, how big the abscess is formed. On the other side, you are seeing multiple carbuncles. And that is because of the severe diabetes. The patient has never cared to control his blood sugar. Okay. And this is the result that happens. These are staphylococcal or streptococcal infections. Most often, if it is staphylococcal, resistant to quite a few antibiotics. This will need a drainage, incision and drainage, and then you can send the pus for culture. But initially, at least, you will have to start with a broad spectrum antibiotic. You can start from the penicillin group. It may be amoxiclavulanic acid. If it is not responding, then we will go to oral cephalosporin. These are carbuncles, again, a skin infection, which is very commonly seen in the diabetic patients. And then we come to the diabetic foot or foot ulceration. And you see the left upper hand picture or right upper hand picture, whatever you want to say. You are seeing two ulcers and they're bone deep, one on the heel and the other on the dorsum of the foot on the lateral side. And these must be the pressure points, or he must be having ill-fitting shoes. He never bothered about it. It caused a bruise and went on to develop ulceration. The other one you are seeing necrotizing fasciitis, and the third one, it has actually formed a gangrenous change along that ulcer edges. And therefore, we must tell all our diabetic patients, and this is a must for all the doctors and also the patients. So it is a doctor's responsibility to show these pictures to these patients and tell them that they have to take care of their feet, because that is very important. So what the patient should do? Patient should never walk barefoot. Okay? With barefoot, he is likely to get many injuries to his feet and to the, to the feet, the whole feet, the sole of the foot, the toes, and everything. Therefore, he has to use the shoes. But the shoes have to be well-fitting. If he is using very tight shoes, why these ulcers he develop? Because of 2 or 3 factors. One, as I told you, pressure points because of arthropathy. Vascular insufficiency because of diabetic vasculopathy. Peripheral neuropathy, therefore he has loss of sensation. So even if he injure himself or if he bruises, he doesn't realize it. And these factors cause him to get repeated injuries and then which are leading to ulceration, infection and ulceration. So the shoes have to be well fitting. It's good to have a shoe with a strap at the back so he doesn't slip off his chappal. If he has a peripheral neuropathy, his chappals will slip off. And therefore, he should have shoes. Now, shoes means what we in our language call boot. If he is using boot, they are too tight. And if they are too tight, first of all, there is no ventilation. There is a lot of sweat. I mean, we are all sweating in this weather. The socks get wet, they become damp, and then there are tight fitting shoes, those pointed boots. There will not be any ventilation, no aeration to the toes, and therefore they are likely to develop, injury and infection. So he should never use tight fitting shoes. They should be well fitting, but never should be tight fitting. He should change the socks at least twice a day. Otherwise, those damp socks with his sweating and the dirt around us, that will cause infection. So he should change them twice a day. He must observe his cleanliness. Washing hands and washing feet frequently is necessary. Then the next thing he has to do is palpate his sole every day for any callosity. If he is developing any callosity or corn like a thing, he must immediately report to the doctor. So he must palpate the sole every day for callosity. And then the last thing, because see, if I am sitting on a bed, I can't bend down and see, look at my sole. Particularly these people, most of them are obese, most of them are overweight, they are aged people. They can't sit cross-legged and examine their soles, and even that examination is not complete. And therefore he has to keep a mirror in front of his sole, and he has to observe or inspect the whole sole in that mirror, and that has to be a daily practice. So when he is examining his sole in the mirror, he will find out if there is any bruise, any injury, any callosity. He should report to the doctor. He has to be very, very particular about the nail care, because as the age advances, the nails become very horny, very thick, and it is difficult for him. There are multiple factors in the aged patient. Maybe his eyesight is poor. Maybe he has some arthritis, so he can't use his nail cutter properly. And therefore, in the bargain, he cuts his skin or injures his skin or a nail bed. Therefore, he has to take the help of another person to cut the nails. It is better to cut the nails with straight scissors so that he doesn't cut the skin at the side. So nail care is very, very important. And when you are establishing now the diabetic care or diabetic clinics in your uh, practice, in that case, you should train your nurse or somebody, some helper who can give all this counseling and demonstration to the patient. So the patient can take care of himself at home. The moment he finds something suspicious, he should report to the doctor. The doctor, whenever the patient comes for his visit, he must examine the patient's feet at every visit. He must do the thorough examination of the patient. We are not treating only hyperglycemia. You see the blood sugar report and write it cetiol, or you increase the dose, or you add some other medicine. That is not the patient care. The patient care, it has to be holistic care. And therefore, whenever the patient comes to you for a follow-up, please examine him thoroughly. Take his blood pressure, because he might be developing hypertension. Ask for his complaints, if any tingling, numbness. Then he has to examine the patient thoroughly. In the examination, you must include the palpation of all peripheral vessels, with a particular attention to the posterior tibial artery and dorsalis pedis artery. If the pulsations are feeble or absent, you are sure that he is developing vasculopathy, and therefore he is likely candidate for diabetic foot. Examine his sensations thoroughly. Now, in the private practice, particularly in the family practice, I will not suggest monofilaments and all, but at least examine all his sensation, the pain, the temperature, and the vibration and joint sense, so that it gives you an idea whether he is developing a peripheral neuropathy, which again is a forerunner for diabetic foot. Examine the sole and look for the arthropathy. So apart from your routine examination of a patient, routinely you have to take his weight, routinely you have to see his blood pressure, see his sugar and all. But I think we have covered it last time that we have to also carry out certain investigations periodically, like his eye examination, his creatinine and other things. So similarly, for every visit that he comes to you for a follow-up visit, please palpate all his peripheral pulsations, particular attention to posterior tibial, dorsalis pedis, examine the sensation, and you can prevent this diabetic foot. Because if the patient develops diabetic foot, it becomes really difficult. It's a challenging problem to treat this patient. And finally, in quite a few of them, it culminates into amputation. Then another common infection that we see in diabetic patients is urinary tract infection. 9 to 14% of the diabetics, they develop urinary tract infection. There is a recurrent urinary infection. It is not one episode. And that is because he is excreting sugar massively in his urine. So it is a very good medium for the bacteria to grow. So recurrent urinary infection, there is a frequency, there is a dysuria, there is a burning. And with this, even the patient comes, frequency that he has to go and pass urine, but every time he passes few drops, it is not a continuous flow. He doesn't get a satisfaction. So this is dysuria and frequency of the micturition. There is a burning. It is better to examine the urine. The commonest organisms which cause the UTI is E. coli and Pseudomonas aeruginosa. So you examine the urine. Just don't go by symptomatology. The urine must show pus cells. If there are pus cells in the urine, yes, 100% urinary infection. If he is getting recurrent urinary infection, first time you may not do urine culture, you can treat with urinary antibiotics and antiseptic. But if he gets second time, we have to do urine culture and sensitivity. We must find out which organisms are responsible and what is their antibiotic sensitivity. According to the antibiotic sensitivity, we have to treat these patients. Now again, in this patient, amoxi would be better. Ciprofloxacin also can be used, proper dosage in both the cases. If you are going to use gentamicin, amikacin, they are injectables. So how you are going to give these injections, please decide yourself, because you might have to give it twice a day. So you will have to call the patient morning, evening. And therefore, I would say that first do urine culture sensitivity, look for the sensitive antibiotic, and then decide about the treatment. The third thing you have to always remember that when you are going to use these aminoglycosides, you have to do the serum creatinine. Without that, please do not use aminoglycoside. Then there is a subset of diabetic patients who get asymptomatic bacteriuria. There are no pus cells in the urine, but the bacteriuria, whenever you do the culture, the bacteriuria is present. And in these are the cases which will require long-term urinary antiseptics. And the best urinary antiseptics, as you all know, is nitrofurantoin. It is not an antibiotic, but it is an antiseptic. It inhibits the growth of these bacteria. And therefore, you have to use it 100 milligram daily, maybe for 3 to 4 months. So this is the treatment of urinary tract infection. Coming to chronic pyelonephritis, if the patient is repeatedly getting, another thing, if the patient is getting recurrent urinary infection, please do sonography for kidney, ureters, and bladder. Recurrent urinary infection, the cause may be diabetes. That is obvious. That again, we must rule out if there is any obstructive uropathy. Because whenever there is an obstruction, there is a stasis, and that is again a good invitation for the bacteria to come and flourish. Okay, so please do sonography to find out if there is any obstruction, if there is any stone, or if there is any stricture, and therefore sonography is a must in these patients. Chronic pyelonephritis, again do imaging, sonography, find out that the kidneys are shrunken. Urine culture and sensitivity, that is a must for these patients, and depending on the sensitivity we will use the antibiotic. And then another common complications that we see in diabetics is perinephric abscess, for which we will need surgeon's help. Pneumonia, the common cause of pneumonia in diabetes, like any other patient, is Staph aureus, streptopneumonia, Klebsiella, Legionella, influenza. Then fungal infections like aspergillosis, cryptoneoformans. At the same time, lung abscess is also quite frequently seen in diabetic patients. It is acute. Now remember, when I'm talking about infection, the first sign or first symptom of this infection will be fever. So if the patient is running fever, not 9900, it has to be more than that. So if he is running fever on the day one, if he comes to you, maybe you take the detailed history. From the history, you can make your diagnosis and then ask the investigations appropriately. But if you can't make up your mind on day one, then just give him crocin or a dolo, antipyretic. But next day, you will find some evidence of the infection, get CBC, leukocytosis will be there. And then depending on, so first localize the infection and then treat it. Don't presume or don't assume. So from his history, localize the infection and then treat it. Pneumonia, again, acute, high morbidity. If the sugar is very high, there can be high mortality also. And therefore, imaging is necessary. X-ray chest alone is not sufficient. Please do HRCT. Send a sputum for culture sensitivity. And what is most important is control the blood sugar. And when you are controlling the blood sugar, we have to use insulin whenever there are such severe or serious infections. Without insulin, we can't control the sugar. We can't rely only on oral anti-diabetics, which he has been taking for years together. Okay, and then use appropriate antimicrobials. Now, there is something called as a Kurth score. And this Kurth score is like this. If the patient has confusion, for each one you give 1 point. For confusion, if urea is more than 70 millimoles, if respiratory rate is more than 30, that means there is a tachypnea. And if the blood pressure is low, less than 90/60. So 1 point for each one. If the score is 1, manage the patient on outpatient basis. If the score is 2, hospitalize the patient. And if the score is more than 3, this patient needs intensive care management. So based on this, decide whether you will be able to treat the patient in your clinic or you have to refer him to a hospital. Coming to diabetes and TB. TB is again very common in diabetic patients. What is necessary is aggressive control of hyperglycemia with insulin. The moment you utter the word insulin, the patient gets scared. But you have to tell him that this insulin will be for short term as long as his TB is there. After that, we will again go back on his oral anti-diabetic drug. Therefore, aggressive control of hyperglycemia with insulin, anti-TB drugs, caution with steroids. Now, many people, use steroids for pleural effusion or maybe it's a miliary. There are indications for steroids, but be cautious because steroids are again going to aggravate the blood sugar. Anti-TB drugs, longer duration of treatment. Then adverse drug reaction will be INH neuropathy. And therefore, always support this with your B1, B6, B12. Management of this is very, very important. You are managing hyperglycemia with insulin. You are giving anti-TB drugs as per our TB control program. But there are coexisting conditions like malnutrition, alcoholism, and substance abuse. So you have to take care of this, without which our treatment can't be successful. Coming to the fungal infection, these are now opportunistic infection because diabetes is an immune compromised state. Candida is very common, mucormycosis, onychomycosis, and aspergillosis. And see, this is rhinocerebral mucormycosis. Starts from the nasal septum, nasal sinuses, and goes on involving the orbit, and then it enters here, as you can see, in the intracranial cavity, and this is how it is spreading. Okay, very devastating condition. We have to treat it with amphotericin and other antifungal drugs. And this is another patient, diabetes, 34 years, male, NIDDM. He came with massive hemoptysis. And when we X-ray chest, he came with the X-ray chest from outside, and this showed a lesion here. Now this is a cavity with something inside. Now this X-ray he also had 6 months back when he was undergoing a surgery, and the surgeon totally missed this particular lesion, and he said that X-ray is normal, so he was operated and all. For 6 months, this patient was asymptomatic. When he developed hemoptysis, he came to me, and as you can see, this is called as a crescent sign. Okay, the name is sufficient to tell you this is a crescent sign. So this was a case of aspergillosis, amphotericin. Along with that, the patient will need surgical intervention. So management, in short, will be personal hygiene, aggressive control of blood sugar, short-term insulin therapy, identify the infection. Just don't treat it blindly. Imaging whenever is necessary. You can do ultrasound, you can do CT. Culture and sensitivity of whatever you have drained, maybe pus, maybe lymph node, maybe sputum, but do the culture and sensitivity. And then it is the doctor's responsibility to select the correct antibiotic, correct dose, correct duration, and decide when the patient needs hospitalization. So I think this is all that I wanted to share with you about diabetes and serious infection. We just take a 2-3 minutes break, and then we'll go on with the pregnancy. Okay, Dr. Asrani?
Yes, ma'am.
Just 2 minutes break, and
Yeah.
can I start? Preeti?
Yes, ma'am, you can start. Yes, ma'am, you can start.
Okay. I'm talking about pregnancy and infections. Now, this has happened, these cases I'm telling you, they came to me. These are patients from Mumbai. They were attending with a gynecologist, and this is what happened. 26 years old, primigravida. She was 5 months pregnant. She was having fever with rigors. The blood showed P Vivax positive. Now, there was a dilemma regarding anti-malarial. So, anti-malarial were not given. She was treated with doxycycline. 3 days later, patient came to JJ Hospital with altered sensorium and seizures. Now, whether it was a complication of malaria or something else. And therefore, we did the CT scan, and CT scan showed cerebral venous thrombosis, which is again a complication of malaria. We should have treated her with anti-malarials. This is another case from Chembur, I am telling you. The family, I mean, both husband and wife were very well, highly educated. 32 years old female patient came for the opinion. 6 years ago, she had 3 months pregnancy, had fever with rigors. diagnosed with malaria, treated with chloroquine. And because she was treated with chloroquine, the gynecologist advised her MTP because chloroquine will have adverse effects on the fetus. So, first child gone. 1.5 years later, there was an ectopic pregnancy. So, tubectomy was done. So, one tube was sacrificed. 1 year later, she missed the period. Urine pregnancy test was positive. So, they were happy that third time she has conceived. 2 months later, there was a lymph node in the neck. Lymph node turned out to be TB, and therefore MTP was done. Poor couple lost 3 children, in my opinion, for no rhyme of reason. The obstetrician at this stage carried out Mantoux test, and Mantoux was positive. Now just imagine a patient in India having Mantoux positive, and because the patient was earlier treated with anti-TB drugs and the Mantoux was positive, the gynecologist told her this is MDR TB. It was a shock of their life to them, and she came running to me. So I, I have yet to hear anybody diagnosing MDR TB on the basis of positive Mantoux. Okay, and this is happening in metro city of Mumbai. So my appeal to you all that be very careful, be very conscientious when you are treating your patients. In case of any difficulty, you can take the second opinion, but don't lose the patient's lives like this. So when we are talking about pregnancy, we are concerned about the mother, the obstetric outcome, and the fetus or the newborn. Fetus and then the newborn. Now, vertical transmission. There are infections in the mother which are vertically transmitted to the fetus. And therefore, let us see when the embryogenesis is taking place. The first trimester, organogenesis, takes place between 4th to 12th week, and hence maximum fetal malformations occur in the first trimester. Therefore, we have to be very, very cautious when we are using any drugs in the first trimester because of the organogenesis. Second trimester, degeneration of cytotrophoblast layer of the placenta, potentiating entry of organisms like syphilis. But now syphilis has almost become obsolete. This was previously, of course, at some places we still have it, but not a very common problem now. And third trimester, maximum transmissibility of the infection, but least malformations. Because by the third trimester, most of the organogenesis has occurred. So organogenesis between 4 and 12 weeks, and therefore, if you use any inadvertent drugs, maximum fetal malformations in the first trimester. So please refrain. Please tell the patients also not to take any drugs inadvertently in the first trimester. What are the routes of transmission? In utero, that the infection can be transferred to the fetus. Perinatal, when the child is coming through the birth canal, and then postnatal. Okay, neonatal meningitis, sepsis, pneumonia, E. coli infections, listeria, genital herpes, hepatitis B, and HIV. And lastly, the other route of transmission is through breastfeeding. So these are the routes of transmission to the fetus or to the newborn. So that also we have to be aware. Why in the pregnancy there is an infection? Now when the fetus is growing in the body, fetus, let us take it something as a foreign body, isn't it? It is not her own self. So for the fetus to survive, the mother's cell-mediated antibody and cell-mediated immunity is decreased. Okay, otherwise it will react to her own fetus, and therefore there is a suppression of cell-mediated immunity, decreased lymphocytic proliferative response, decreased natural killer cell activity. We'll do this all in next time. Immune suppressive fetal products. Even fetal products suppress the mother's immunity so that the fetus can survive. Okay, and therefore the pregnant woman is susceptible to infection. Now, when we are talking about infections in the pregnancy, we have to consider the drug safety in pregnancy. And if you take any drug index, and you will find that they have classified the drugs like this. Category A, there are control studies in the pregnant women which showed no risk, okay, fetal malformation. So that is category A. Category B, adequate human studies have been done, but animal studies showed some risk, some risk. Okay, so that is category B. Category C, risk cannot be ruled out. So that means there is a risk. Category D, positive evidence of risk is there and therefore they should never be used. Category X, contraindicated in pregnancy. So just as a not out of interest, not out of curiosity, but for a good practice, please make a list of these antibiotics which are safe, which you can use during the pregnancy. Again, as far as possible, avoid them in the first trimester. Penicillin, macrolides, cephalosporins, carbapenems, they are in the B group. They're safe, but some risk shown in the animal studies. Chloramphenicol, quinolones, fluoroquinolones, C, so risk. Tetracycline, contraindicated. Pneumonia can occur in this patient. Bacterial causes are streptopneumonia, H. influenzae, Legionella, Mycoplasma. Viral varicella influenza. Fungal infection if she is HIV positive, PCP, cryptococcal, and aspiration pneumonia. Okay, so please remember about community acquired pneumonia and aspiration pneumonia. Again, the same curve score and give 1 point to each one. If there is more, the score is more than 3, patient needs ICU. Score more than 2, please send the patient to a hospital. Score 1, manage the patient in your outpatient department. Clinical course remains the same like any non-pregnant adult patient. Organisms are same, streptopneumonia, H. influenza and all. Drugs are beta-lactams, macrolides. Quinolones not to be used, not to be used. Okay, so beta-lactams you can use amoxi, you can substantiate it with amoxiclav, you can use macrolides, azithromycin. These are safe and they can be used for pneumonia in the pregnancy. Beta-lactam plus, if there is a serious severe infection, can be used, but again there are inadequate safety studies. In America, their guidelines are so strict that the patient has to be counseled about the safety. He is given all the therapy counseling, and with the consent of the patient, then only these drugs are used. This is H1N1. Again, coming back, so oseltamivir. If there is only upper respiratory infection, no pneumonia, oselta 75 milligram BD for 5 days. Symptomatic patient at day 5, the above dose is continued for 10 days. Pneumonia, but there is no tachypnea, then we give the dose 150 milligram BD for 10 days. And if there is a tachypnea, patient should be hospitalized. Naturally, this is for H1N1, and in this stage, the patient will not come to you. But if he comes, then the patient should be hospitalized. And vaccination should be advocated to all these people. Coming to dengue is another common infection that is around. Now, dengue, monitor the hemoglobin. Most important is hematocrit. If there is a concentration, hemoconcentration, the hemoglobin will go on increasing. So measure the hematocrit, see the platelet count. If the hematocrit is rising, hemoglobin is rising, hydrate the patient. That is the first and the most important thing. If the platelets are less than 20,000, then only give platelet transfusion. Otherwise, during labor, the patient may go into PPH, the neonate will suffer. The complications of dengue will be preeclampsia, eclampsia, premature birth, stillbirth, and fetal infection of dengue. So please counsel the patient, tell them that there could be problems because there is a dengue, but you are managing it. If you are confident you can manage, because if the platelets are high, hematocrit is not rising very fast, there is no need to hospitalize, you can treat the patient. Otherwise, it is better that you send him for hospital to the hospital. Urinary tract infections in pregnancy is very common. Asymptomatic bacteriuria is common. Same microbes as I told you in the adults. Beta lactam should be used, that is cephalosporin. Quinolones to be avoided. Sulfonamide, never, never. Septran, no. It has become obsolete now. So no quinolones, no sulfonamides, no, because they are teratogenic. Beta lactam plus for extended spectrum beta lactam. These are in diabetic pregnancy we should use. But again, take the second opinion or refer a patient to a diabetologist and then start using it. Asymptomatic bacteria reported in 2 to 6% of cases. Persistence of actively multiplying bacteria without symptoms is seen. So use antimicrobials for 7 days. Then nitrofurantoin 100 milligram QID for 21 days. And then after that, nitrofurantoin 100 milligram once a day throughout the pregnancy. Tuberculosis. If the patient comes, pregnant lady with tuberculosis, sputum for AFB culture and sensitivity. Now, this is an old slide. Today, you can, of course, culture sensitivity is required, but do the gene expert so that at least you can immediately know whether it is rifampicin resistant. If it is rifampicin resistant, it is MDR. In every tuberculosis and every pregnant mother, we have to do an HIV test, and we using the shield, we can use the X-ray chest. If there is lymphadenopathy or any other tuberculosis, you will have to take tissue sample and subject it to gene expert to find out rifampicin resistance. TB treatment in the first trimester, use only HRE. Z, pyrazinamide is not to be given in first trimester. Second trimester, you can use HREZ. Throughout the pregnancy, you have to give pyridoxine. Monitor the visual acuity and color vision because we are using ethambutol. Streptomycin to be strictly avoided because it will cause ototoxicity to the fetus. Hearing impaired, okay? Breastfeeding can be continued. When a tuberculous mother is on treatment and feeding the child, INH prophylaxis to the infant is given for 3 months. And when the infant is on INH prophylaxis, postpone the BCG vaccination. MDR TB, we have gene probes, we have gene expert. Second line drugs have a severe fetal toxicity, and therefore either refer the patient to the highest center, but otherwise counseling for therapeutic abortion is advocated in MDR TB. Malaria, there are large number of malaria cases from sub-Saharan Africa and all over the world. Causes maternal anemia, impaired fetal growth, miscarriages, stillbirths, even otherwise by malaria itself, premature birth, plus there is placental parasitemia, and therefore there is IUGR. 75,000 to 2 lakh infant deaths each year due to malarial infection during pregnancy are reported. So malaria is not so simple. So if a pregnant lady comes with malaria, please tell the family members that malaria per se can cause many problems, the obstetric problems, as well as the treatment can also have some side effects. Take the consent and then start treating the patient. Quinine is oxytocic. Higher doses cause malformation, 8-nerve hypoplasia, limb anomalies. Depending on the type of malaria, chloroquine is safest. Quinine if it is indicated. Nowadays, we don't use this artesunate to be used, but adequate data of the safety is not yet available. And then you know this artemisinin combination therapy, which is called as ACT-ACT, fixed drug combination. You have artemether lumefantrine, which is commonly used. You can see this table tomorrow. So if a patient comes with malaria, but first tell the family members, take them into confidence, tell them this is malaria. Malaria per se can cause complication, and treatment also may add to the complication. They should be prepared for that because after all, mother's life is given preference over the child. If the mother remains alive, then she can conceive again. Hepatitis B, perinatal transmission, if the mother is HBsAg positive, 10 to 20%. If she is also HBe positive, then the HBV perinatal transmission is 90%. If the mother has not received any treatment, then what we have to do is we have to keep hepatitis B immunoglobulins ready. They are available. 1 to 2 ml, that is 200 units, are given intramuscularly. 0.5 ml immediately after birth to the child in case of HIV positive mother. And immediately the hepatitis B vaccination is started to the child. Okay, the mother is positive. Nowadays, there are so many treatments for hepatitis B. And if the mother is positive, please find out whether she is already on treatment. Avoid hepatotoxic drugs, biosafety measures to be taken. Now, this is abstain from alcohol. Alcohol consumption is increasing in our society. This I used to have a good hearty laugh. I used to feel that this is only for Americans. No, I am seeing middle class, higher class, lower class. The consumption of alcohol in the women is increasing in India. Counseling for vertical transmission. Give hepatitis A vaccination to the mother. No indication for MTP just because she is hepatitis B positive. HCV infection. This is common in intravenous drug users or if there is a history of transfusion. If there are liver enzymes are abnormal or if the patient is a recipient of organ transplant, the donor might have been HCV positive. Anti-HCV antibodies to be measured. HCV RNA is to be measured. If it is less than, if it is negative, then there is a low risk of transmission. But in most of the cases, a therapeutic abortion is advocated if they are positive. HIV infection, all pregnant mothers to be offered HIV test. This is as per national guidelines. If seropositive, send for CD4. But nowadays, we don't start treatment based on the CD4. All the patients, irrespective of their CD4 count, all male, female, irrespective of their CD4 count, we start them on antiretroviral therapy. It is better to refer a patient to ART center where the patient will be started on treatment irrespective of CD4 count. And this is the treatment: antenatal, intranatal, postnatal, tenofovir, 3-TC, lamivudine, and efavirenz. And then the child also has to be given the dose of nevirapine, which I have given below. HIV-2 infection, it is AZT plus lamivudine, 1 tablet twice a day. Along with that, ritonavir, lopinavir, 2 BID. Okay, so for HIV-2, the regimen is slightly different. And then again, baby is to be given AZT syrup for the baby, less than 2.5 kg, 10 milligram BID, and more than 2.5 kg, 15 milligram BID. Vaccinations during pregnancy. How safe are vaccinations during pregnancy? We should not give live virus vaccines during pregnancy. Hepatitis A vaccine produced from inactivated virus. Theoretical risk to the fetus is very low, so it can be given. Hepatitis B vaccine, non-infectious. This is recombinant DNA technology. Therefore, there is no risk. MMR not to be administered to the mother. Varicella not to be administered. BCG not recommended. So if anybody, I always tell you about preconception counseling. So this should be a part of preconception counseling. And if they are not vaccinated, they should be vaccinated before conception. So please remember these guidelines when you are managing a pregnant mother. Thank you very much for your patient hearing. Okay.